Okay, hello everyone. Assalamu alaikum. My name is Salsabil. I'm currently a fifth year medical student, and today I'm going to be, inshallah, covering all of the OSPE objectives and hopefully the SAQ objectives as well. My contacts are here, my email, my phone number. You can contact me in any way during the session. If you have any questions, feel free to interrupt me. If after the session or after you watch the recording, let's say in the future, if you have any questions, also please feel free to text me. Okay, let's go ahead and get started. So just to orient ourselves a bit, these are the morphological objectives. I've received this picture from many people when I asked like, oh, what did the doctor specifically stress on? So this is exactly what you need to know for the OSPE, right? Here, uh, all of these things are covered in the lectures. The one thing that's a bit scary is this other morphology covered in lectures. This essentially opens up the topic to anything, you know? So it's really important that when you see a picture in the slides, to understand the context behind the picture and to kind of remember the picture a bit. Okay, so I would suggest either use my presentation or the lab committee's presentation. I saw there was a nice OSPE document as well. Just before your exam, quickly sort through the images or just quickly browse through the images and see whether or not you can kind of recognize it in one go. Okay, so by the time you're doing your final revision, you should be able to see the picture and instantly decide at least one or two differential or three differential max. Okay, so these are the morphological objectives. Now there is a formula to OSPE and SAQs. Okay, and the formula is very universal. It can apply to any question, any topic, it's not specific to this block. But for any OSPE or any SAQ question, there is a context. In other words, there will be a common scenario that's given, common like signs or symptoms, a picture for OSPE, important, and either they'll ask you for the causes, they'll ask you how to diagnose or the most diagnostic test, the diagnosis itself, or the treatment. Okay, treatment in very select cases. It's more for fourth and fifth years, but treatment in very select cases, we'll see. Now, this sounds very obvious, obviously, like, you know, obviously they'll give you context, picture, diagnosis, and all of that. Can you hear a lot of background noise, or is it fine?
Oh, it's clear.
Okay, thank you. Okay, so it seems very obvious here, but the catch is, or like how to use this information is that whenever you see any picture or anything that's OSPE worthy or SAQ worthy, you need to have a mental checklist in your mind that, okay, do I know what common scenarios they can ask me this in? What are the common signs and symptoms? What is this picture? Can I interpret this picture? What are the common causes? How can I diagnose? What is the diagnosis? And can I treat it? Okay. So this is a common checklist or like a universal checklist that you should have in your mind for any common disease that you're studying for the block. Okay. And this is going to help you in the MCQ, OSPE, and SAQ. Just make sure to cover all of these bases. Okay. So let's start off with hematology. We'll cover all of the blood abnormalities, normalities. Let's see. Okay. So this is a normal CBC. Okay, in the normal values. So hemoglobin, this is important to us because a low hemoglobin will indicate anemia, right? RBC count is also important for us because also it will indicate anemia. Hematocrit, not that important. It indicates the amount of, let's say, hematocrit or the amount of blood in the whole entirety of our plasma volume or like the blood volume, how much is of it is red blood cells, right? Then we have the MCV, MCH, and MCHC. These are very important in the context of hematology. So MCV, you can think of it as mean cell volume. It's mean corpuscular volume, but mean cell volume is easier to understand. It's the mean volume of the cells. Very easy. So if it is high, it's called macrocytosis. If it is low, it's microcytosis. Okay, then you have MCH, which is mean cell hemoglobin or mean corpuscular hemoglobin. This is the mean hemoglobin per cell uh, of uh, of the red blood cell, right? So if you have low hemoglobin, that's going to be hypochromic. If you have high hemoglobin, that's going to be hyperchromic, but that's not really common. Then you have MCHC. MCHC is the mean concentration of hemoglobin per red blood cell. Okay? So mean concentration of hemoglobin per red blood cell, this is very important in one specific case that I will discuss later. And yeah, so reticulocytes, it shows whether the bone marrow is reacting to this anemia or not in our context specifically. So if you have high reticulocytes, that means that, okay, sure, you have anemia, but the bone marrow is compensating for it by producing more and more reticulocytes, which are like let's say immature or premature red blood cells, right? Okay. Then you have WBCs. We know that neutrophils are the most common. Then you have lymphocytes, monocytes, eosinophils, and basophils. So eosinophils are pink, basophils are blue. Neutrophils are lobed and granular. They produce, they're myeloid cells, so they produce myeloperoxidase. And yeah, we'll move more onto these later. And platelets are platelets. You can have thrombocytopenia or thrombocytosis depending on the diseases. Okay. One thing I wanted to mention is that this session is going to cover almost all of OSPE. And for SAQ, you have to keep in mind that SAQ can essentially be from anything, right? It can be from things that are considered mainly from MCQs, right? So SAQs can really come from anything. So I couldn't obviously like cover everything that can come in SAQ, so keep that in mind. However, I will stress on things that more commonly come in SAQs, inshallah. Okay, so now can anyone tell me what is wrong with this? This is a peripheral blood smear.
Hypochromic.
Hypochromic, okay. Okay. Yes, it might appear hypochromic. However, sorry, I shouldn't have said yes. This is actually a normal peripheral blood smear. And I brought this very intentionally because sometimes we get so caught up in pathologies, we forget to kind of appreciate or remember what is normal, okay? So although here it appears hypochromic, one thing to remember is that hypochromia is only if the central pallor is more than a third of the cell, okay? So how do we, whenever we get a histological image, how do we interpret it? It seems very overwhelming sometimes. So first of all, you look at any obvious abnormalities, anything that's sticking out to you. Is there like an inclusion in the cell? Is there a parasite? Is there an abnormal shape of the cell, right? So something that's obviously abnormal. If not, it's fine. Take it easy. Take it one step at a time. So we know the two main components are the RBCs and the WBCs in the cell, right? And there are platelets whatever in specific cases. So first of all, we look at either the shape, the size, or the or the number of either the RBCs or the WBCs. So we look at the number, shape, and size of the WBCs, and then the number, shape, and size of the RBCs. Okay, so for WBCs, this can also mean the lobes, the shape. It could be atypical lymphocytes. It could be hypersegmented. For RBCs, as you mentioned, it could be hyperchromic with increased central pallor. It could be microcytosis, etc., etc., etc. Okay, so now that we know what's normal, this is normal. So we have normal neutrophils with normal segmented granules. Lobes. Can anyone tell me what is the normal number of lobes that a neutrophil can have?
3 to 5, I think.
3 to 5. Perfect. Yes. So if it's more than that, we'll call it hypersegmented. Okay. So let's move on. Now that we know normal, now what is this? What is this indicating?
Now this has to be hypochromia.
Exactly, yes. So this is hypochromic microcytic anemia, also known as iron deficiency anemia. So what are specific things that we can see here? So we can see increased central pallor or hypochromic microcytic anemia. So small cells, increased central pallor. We can also see some target cells sometimes here. Okay, can you see my pointer?
Yes.
Okay, perfect. Okay, so we can see target cells sometimes. We can see pencil cells sometimes. And I believe that's it. So these are common for iron deficiency anemia. Now, as I mentioned before, for anything, you need to know the context. So what is the most common context? In in iron deficiency anemia, it is usually a woman with heavy menstrual bleeding. So as soon as you see in the OSPE a woman with heavy menstrual bleeding, you have to keep in mind iron deficiency anemia. What other context it could be? It could be an older man with, let's say, some sort of decrease in appetite, weight loss, B symptoms. What am I indicating here? What could it be?
GI bleed, chronic.
GI bleeding, exactly, due to malignancy or due to peptic ulcer disease, right? And what is the most common cause worldwide for iron deficiency anemia?
Worms.
Hookworm, yes, very good. Yes, so hookworm infestation is the most common cause. So it's very important to remember the context. Hookworm infestation, menorrhagia, GI bleeding, peptic ulcer, etc., etc. Okay, then signs and symptoms of anemia, as we know, fatigue, pallor. It could be shortness of breath, pica, which is an urge to eat things that are not edible. And then it could be leukonychia, koilonychia, so signs in the nails. And interpretation of histology, as we mentioned. So hyperchromia, microcytia, and then microcytosis, actually. Okay, and then pencil cells. What else? Target cells. Okay. All right. Diagnostics. So how do you diagnose iron deficiency anemia? First, you do CBC CBC, you see hyperchromia, microcytia, and then you see peripheral blood smear. So this is what you see in the peripheral blood smear. Now, when you suspect iron deficiency anemia, you do something called iron studies, right? So you check for ferritin, you check for transferrin saturation, TIBC, etc. So diagnosis, we know here, and the treatment is going to be obviously supplemental iron and also treatment of underlying cause. So if there is if there is GI bleeding, you treat the GI bleeding. Okay. All right. So now let's look at each of these markers and see how they are increased or decreased in iron deficiency anemia. So hemoglobin, it's going to be low. That is the number one marker for anemia, obviously. MCV is going to be low. In other words, it's going to be microcytic. MCH is low, so hypochromic. RDW. So in iron deficiency anemia, as you can see here, about these cells, do you think they're of the same size or the same shape, or do you think they're different?
They have to be different because based on the availability, right?
Exactly. Yeah, so it's a deficiency anemia, right? So not all cells get the same amount of iron and they are deficient in iron. So these are different kinds of sizes. So in other words, it's called anisocytosis. And also there are different kinds of shapes, right? So not all of them are same shaped. So they're pencil shaped, some are normal, some are abnormal. So this is called poikilocytosis. So there is anisocytosis and poikilocytosis. Now, about RDW, what is RDW? It's the red cell distribution width, which means that what is the range of the sizes of the cells? So here, as you can see, there are different kinds of cells, which can range from very small to normal size, right? So this is going to have a huge range. So here, RDW is going to be high. Okay? So this is used to usually differentiate between another disease. Can someone tell me what RDW is used to differentiate between? Iron deficiency
Thalassemia.
and thalassemia. Very good. So in thalassemia, since it's like an inherited disorder, all of the cells are going to have the same DNA. They're going to produce the same denatured hemoglobin or the same abnormal hemoglobin. And this is going to cause all of the cells to be abnormal, but similarly abnormal. So this is going to have a smaller RDW. However, in iron deficiency anemia, it's going to have a high RDW. Right? Okay. Reticulocyte count, since it's a deficiency, it's going to have a low reticulocyte count. Okay, now we move on to the actual iron study. So ferritin is going to be low. Ferritin indicates iron storage, and it's going to be low. Can anyone tell me about TIBC? Is it going to be low or high?
It's going to be high because the body needs to look up for any iron.
Exactly. So TIBC stands for total iron binding capacity. So if you have low iron in the blood, obviously its ability to bind to more iron is high, right? So the TIBC is high, ferritin is low, transferrin saturation is also low, and serum iron is also low. Okay, so now you give them supplemental oxygen. What is the first thing that is going to increase? Okay, so the first thing that is going to increase is the hemoglobin. Okay, then you have increase in all of this, and then finally you have increase in the ferritin. However, when you have anemia, the first thing that is going to decrease is ferritin, then all of this, and then finally you see changes in the blood. Okay, so the first, when you have decrease in ferritin, you have like asymptomatic anemia, let's say. Okay, so first you have decrease in ferritin, then you have decrease in TIBC or transferrin iron or and serum iron. Then you have changes in the blood through low hemoglobin. Okay, however, when you give supplemental iron, it goes the opposite way. So first you see changes in hemoglobin, and then in all of this, and then finally the storage. Obviously, you want to fill in the storage last after you have availability in the blood. Okay, so we discussed everything here. So remember the interpretations, they might ask you in the OSPE, interpret this image. So you'll say hypochromia, microcytic anemia, poikilocytosis, anisocytosis, target cells, and pencil cells. Okay, for your diagnostics, they might ask you what further investigation do you do? So you do RN studies and you do investigation of underlying cause. So underlying cause, it could be endoscopy if it's an older male. It could be colonoscopy if we suspect colon cancer, etc., etc. Okay, supplemental iron and treat underlying cause. Okay, now next. So can anyone tell me what this is indicating, or what are you seeing here? Anything?
Hypersegmented neutrophil.
Yeah.
So it's megaloblastic.
Yes, it's a megaloblastic anemia. And what about these cells? What do they indicate?
Large RBCs.
Yeah,
So
exactly. Macrocytes, yes. So these are macrocytes. Sometimes they're called oval-shaped macrocytes. And this is a hypersegmented neutrophil. As you can see, there are 1, 2, 3, 4, 5, 6, 7, 8, 8 lobes. So that's very hypersegmented, right? So normal is 3 to 5, as you mentioned. Yeah, so this indicates some sort of megaloblastic or macrocytic anemia. So what is the context here? Context, common scenarios could be a patient on a prolonged vegan diet, or an alcoholic patient, or it could be someone who has underwent gastrectomy or ileal resection, or someone who has pernicious anemia. Okay, so in pernicious anemia, can you tell me what you look for? What further investigation would you do?
intrinsic factors, antibodies.
Exactly, intrinsic factor antibodies. So you look for antibodies to intrinsic factor, which binds to B12 and is supposed to absorb B12. However, in pernicious anemia, this is absent, hence the anemia. So signs and symptoms, similar to anemia, fatigue, pallor. It could be normal symptoms of anemia or symptoms of the underlying disease as well. However, for B12 and folate deficiency, which are the two most common causes, sorry, got disconnected. I'm going to share my slides again. Okay, so can you guys see my screen?
Yes.
Okay, perfect. Um, so did you hear the part about where I said about macrocytic anemias, B12 deficiency, the difference?
I don't think so.
Okay, okay. All right. So for context, um, uh, okay. So context usually is going to be alcoholics. It's going to be patients who underwent ileal resection or gastrectomy, or if they have pernicious anemia, or if they are prolonged like vegan diets or vegetarians. Okay. Signs and symptoms. Again, signs of anemia, fatigue, pallor. Um, so what is one key difference in symptoms between B12 and folic acid deficiency?
They have beefy tongue.
Beefy tongue, okay, but I believe that's with both. No, actually, yeah, it's with B12 deficiency. However, there is one key difference, which is in neurological symptoms. Okay, so neurological symptoms are seen with B12 deficiency, but they are not seen with folic acid deficiency. Okay, so that is one thing that can be used to differentiate folic acid and B12 deficiency, and it's very important for SAQs. Okay, interpretation to histology, we said that these are macrocytes and they're hypersegmented neutrophils. Diagnostics, we can do B12 and folate levels, okay? However, if the B12 and folate levels are, so these are things that we already covered. If the B12 and folate levels are, let's say, borderline, you can't really differentiate, you will do something called MMA and homocysteine levels, okay? I know I already showed it, but if homocysteine levels are high, can that differentiate B12 and folate?
No,
No, exactly. If MMA levels are high, is that folate or B12 deficiency?
B12.
B12, perfect. So, high homocysteine is present in both folic acid and B12. However, high MMA is present in B12 deficiency only. You can remember this by homocysteine, so it's like homogeneous in both. Okay. However, MMA is the one that stands out, or it's only in B12. Okay, so this is how you diagnose B12 deficiency and folate deficiency. Then you can undergo further investigations. You can do intrinsic factor antibodies. You can check for, history, check for alcoholism, vegan diet, etc., etc. Yeah, so that's the approach to B12 and folate deficiency. Okay, I think this is not loading. So we can see from here. The internet is really bad. Just a second. Okay. I kind of already showed the answer, but okay, what are you seeing here? Okay, here you're going to see something called target cells. Okay, so you're seeing target cells here, and this is something called HPLC or liquid chromatography, or in other words, it's electrophoresis as well. It serves the same purpose. So these are done for a group of disorders called hemoglobinopathies. Okay, so which can either be thalassemia, sickle cell anemia, etc., which can be alpha and beta, etc. Okay, so here we're seeing hemoglobin A is 94.4, fetal hemoglobin is less than 1, A2 is 5.6%. This is seen in what condition?
Thalassemia minor.
Thalassemia minor or thalassemia trait, right? Okay, so how do we know this? Because A is low, but it's not that low, right? It's not 30 or 40%. It's 94.4, which is less than 95%. However, A2 is high. What is high levels of A2? It is more than 3.5%, okay? So more than 3.5% of A2 is high, and this is seen in beta thalassemia minor. Okay, beta thalassemia trait and better words would be minor. Okay, so signs and symptoms, again, symptoms of anemia, usually a young patient. It could be patients who are of Middle Eastern origin, or let's say they have um, a lot of consanguinity in their family because this is an inherited disease, right? So, interpretation of histology, you see differently shaped. It's not differently shaped, first of all. It is here, it might seem differently shaped, but it's not actually differently shaped. So, the RDW is going to be low. You can see target cells. And you can see nucleated RBCs as well sometimes because the cells that are being produced are not serving the purpose well, right? So the bone marrow reacts by producing more and more RBCs, hence the presence of immature or nucleated RBCs in the bloodstream. Here you cannot see it, but sometimes you can. Okay, so diagnostics, again, it's going to be hemoglobin electrophoresis or liquid chromatography and liquid chromatography. The diagnosis, as you mentioned correctly, and the treatment is going to be dependent on whether it's thalassemia minor or major or intermediate. Okay, now, if you see this hemoglobin electrophoresis, Here, A is only 11.7%. There is no A2, and fetal hemoglobin is 88.3%. What is this?
This is major.
This is major for sure. Okay, so here, indicated by the high levels of hemoglobin F, this is produced in fetus because this has a higher affinity to oxygen. Okay, however, in adults, in thalassemia major, the hemoglobin that is produced is already faulty, right? So the body reacts to this by producing a hemoglobin F, which has gamma chains, and gamma chain has a higher affinity to hemoglobin. Higher affinity to oxygen. So normally this is not present in adults. However, in thalassemia, because of a reaction to this faulty hemoglobin, the body keeps producing gamma chains and keeps producing hemoglobin F to kind of oxygenate. But this is already a very aggressive disease. And yeah, context is going to be the same. Signs and symptoms is going to be more aggressive. Histology, you can still see nucleated RBCs. Yeah, here you can see nucleated RBCs, not so much in minor, but here more. You can see target cells and normal RDW. So diagnostics, again, hemoglobin electrophoresis. Diagnosis, we know. And treatment is going to be blood transfusions. It can be hematopoietic stem cell transplant. Okay. So what are these things that you see in beta thalassemia major? Let's start with this one. So what are you seeing here?
This is the chipmunk face, I think.
Exactly. Chipmunk face or thalassemic facies seen with beta thalassemia major or intermediate as well sometimes. So for intermediate and major, the difference, they don't usually ask you to differentiate. However, intermediate presents a bit later in life, let's say 20-year-old male, as in your LGD as well, it was one of the cases. Whereas major presents earlier in life because it's more severe, right? So this, if they ask you to interpret, this is depressed nasal bridge and maxillar hypertrophy. So the maxillar bone is hypertrophic and there's depressed nasal bridge, which causes this classic chipmunk facies or thalassemic facies. Okay, then you have, what is this?
Hair on something.
Yes, perfect. So this is hair on end appearance, which is seen in skulls and also in some other bones. You can see in here as well, hair on end appearance. And here, as you can see, the patient's abdomen is very distended. Can anyone tell me what is going on here?
Splenomegaly.
Splenomegaly. Okay. So what happens in beta thalassemia major is that the hemoglobin that is produced is not enough for oxygenation. So this is why the body tries to react to it by causing something called extramedullary hematopoiesis. Okay, so there is this can be in the spleen, and this can be in the um, uh, other bones, let's say. Okay, so this causes increase in hematopoiesis. Hence, we see nucleated RBCs or immature RBCs. We see massive splenomegaly or hepatosplenomegaly. And we can also see hair on appearance or in the skull. So these are very important pictures to keep in mind and keep going through them. Okay, so these are everything we mentioned. If it's thalassemia minor, it's transfusion independent and patients remain asymptomatic for a majority of their life, whereas if it's major, it's transfusion dependent. Okay, so they require frequent transfusions. Okay, so this is something I brought for kind of reference. So here you can see hemoglobin electrophoresis. For trait, you have increase in A2, whereas for major, you have increase in hemoglobin F. That's the major difference, okay? This is something we'll touch on later. So in thalassemia minor or trait, one of the hemoglobins is going to be normal. One of the beta chains, sorry, not hemoglobins, beta chains is going to be normal. And the other one is either going to be zero or absent, or it's going to be plus, which is a faulty or abnormal hemoglobin. So this results in asymptomatic mild anemia. Whereas for intermediate, no, let's talk about major. So if you know trait and major, you can figure out that everything else is intermediate. So major is going to be if both of the both of the beta chains are absent or zero. And this causes severe anemia, extramedullary hematopoiesis, all the signs that we saw. Intermediate, it can be either one of the chains is absent or if both are abnormal or if there are some other issues. So there is epsilon here. Anyway, you don't need to know. So there is iron overload, possible extramedullary hematopoiesis, and moderate anemia. Okay, so now can anyone tell me what this is? So, what is the disease seen here? Okay, so this is going to be hemoglobin H disease. This is also mentioned in your LGD. That's why I thought of bringing it here. So here, A is normal, F is normal, A2 is normal. But they found something else, as they mentioned in the chart here as well. They found positivity for hemoglobin H disease. Okay, so this is hemoglobin H disease, which is a type of alpha thalassemia. It's not a type of beta thalassemia. Now, here, as you can see, usually we see kind of like pinkish, or this is yellow, sorry. So pinkish histological slides, but here it's different. So can anyone tell me if this is a special stain and what is the stain? So this is going to be a supervital stain, okay? So yeah, so this is going to be a supervital stain, and this appearance, can anyone tell me? It is a golf ball appearance. Okay, so this is seen with hemoglobin H disease, which is a type of alpha thalassemia. Okay, diagnostics again is going to be liquid chromatography, it's going to be hemoglobin electrophoresis, diagnosis, hemoglobin H disease, and treatment is going to be similar to beta thalassemia. Okay, so here they found something called hemoglobin D. Everything else is normal. No, actually, A is low, but this is hemoglobin D. Okay, so this is something that is seen commonly in the Indian subcontinent, sorry, the Southeast Asia, basically. So India, Pakistan, Bangladesh, and it's something called hemoglobin D Punjab. And this is something that was mentioned in LGD, and I mentioned here for the sake of completion. However, it's I don't think there's much to know about it. It's just if there's D, it's hemoglobin D Punjab, and you need to screen the family for you should do genetic testing because they have risk of hemoglobinopathy such as sickle cell anemia, thalassemia, hemoglobin S D disease or SCD disease or like combined hemoglobinopathies as well. So that's the only significance. Okay, so now can anyone tell me what is the problem here?
Sickle cell.
Yeah. So sickle cell trait. Okay, how do we know it's trait? Here, as you can see, hemoglobin S is low, lower than hemoglobin A. Okay, so majority of it is still normal hemoglobin, but some of it is sickled. So this is sickle cell trait. Okay, and the patient might present with hematuria or mild symptoms of anemia, but usually they're asymptomatic. So context, they can be they can be asymptomatic patients if they're a sickle cell trait, or they can present with hemoglobinuria, and they might have a family history of consanguinity or family history of sickle cell anemia. You need to do genetic testing. So diagnostics is going to be, again, for hemoglobinopathies, hemoglobin electrophoresis, liquid chromatography, and you need to do a genetic testing for the family, even premarital screening or testing as well. Okay, treatment is usually supportive treatment. However, for this, here S is going to be 91.1%. So this is sickle cell anemia. Okay, and what can we see here? Two things we can see here.
Sickled cell, like the oval shape, not oval shape.
Yeah.
هلال شكل هلال.
Sickle cells and also target cells. We can see here some of them are target cells. Okay, so this is sickle cell anemia. As you can see, there's almost no normal hemoglobin. Majority of it is sickled. Okay, so what is the context here? Again, someone, let's say, of African American origin coming in with family history of sickle cell anemia, frequent ER visits. Why do they have ER visits? It's mainly because of vaso-occlusive crisis. So they can present with chest pain, they can present with other like bodily pain. This is because of vaso-occlusion. So when there's any kind of stressor in the body, let's say low oxygen or any kind of infection or anything else, it can precipitate this condition. In other words, it can cause the hemoglobin to become denatured and cause the red blood cell to become sickle-shaped. And what this does is it can get stuck in very small capillaries and very small vessels. And this can cause vaso-occlusion, and this can cause ischemia, damage to the nerve, or like stimulation of the nerve, and this can cause immense pain. Like this is very, very painful. We once saw a patient in the ER. They could not speak, they could not move, they were in so much pain. Okay. So this is a very important condition to know about, especially in our regions where consanguinity is high. So those are the signs and symptoms. Interpretation of histology, as you correctly mentioned, so there are sickle cell shaped cells, and there is going to be target cells as well. Diagnostics, again, hemoglobin electrophoresis, premarital screening, etc. Treatment is going to be, first of all, you do symptomatic treatment. So you give them oxygen, you give them morphine to treat their pain, and you also treat them with hydroxyurea. I don't think the treatment's very important here. I'm not sure if you took it in pharmacology, but hydroxyurea, you can give folate, etc. Okay, so yeah, frequent ER visits, a pain crisis, low hemoglobin, normal MCV, MCH. It's a normocytic normochromic anemia. So there is nothing wrong with the chromia or the hemoglobin content. It's more of the quality of the hemoglobin that's being produced. Okay, so it is an autosomal recessive substitution mutation of glutamic acid to valine. So glutamic acid is hydrophilic. When it is replaced with valine, which is hydrophobic, this causes the hemoglobin to become sickle-shaped. Okay, so you do treatment of pain crisis, regular blood transfusions, and a definitive, this is supposed to be SCT or stem cell transplant. Now, can anyone tell me what you're seeing here? So this is Howell-Jolly bodies. Okay, so these are small inclusions inside the cells, and this is seen in patients who undergo splenectomy, or they undergo something called a functional asplenia. And I put this here because this is seen especially in the context of sickle cell anemia. So when they're very young, sometimes because of these sickle cells and because of all the vasoocclusion in the, sorry, in the reticular endothelial system in the spleen, it makes sometimes the spleen kill itself, basically. So it's functional asplenia or autosplenectomy. So the body essentially kills the spleen itself. And what happens is you start seeing these abnormal cells, which would otherwise be caught by the spleen, but now is not being caught by the spleen. So you can see Howell-Jolly bodies. And this is very specific for hyposplenism. Okay, so now what can you see here?
Spherocytosis.
Spherocytosis. Very good. Okay, so what can you see here? Oh, you can see spherocytes. Very, very distinct picture. Okay, so the context, maybe the patient is a young patient who is presenting with signs of anemia. They can also present with jaundice, hepatosplenomegaly. So jaundice and hepatosplenomegaly, can you tell me what type of anemias they usually present with?
Hemolytic.
Hemolytic anemias. Why? Because in hemolytic anemias, you have increased hemolysis, right? So this increased hemolysis, heme is hemoglobin lysis or RBC lysis. This is basically heme plus protoporphyrin. And protoporphyrin, it goes to the liver. It gets accumulated if there's a lot of lysis. The liver cannot empty it fast enough. And this will cause jaundice, which is the pigment from biliverdin or urobilinogen, biliverdin, basically bilirubin. And this will cause jaundice, and it also accumulates in the spleen and the liver, and this will cause hepatosplenomegaly. Okay, so this is, as you mentioned, spherocytes, classically seen in hereditary spherocytosis. Now, I want you to mention some mutations. First of all, what is the mode of inheritance? Okay, so we're going to diagnostics. So what is the mode of inheritance of hereditary spherocytosis? So it is going to be autosomal dominant. Okay, so it's an autosomal dominant mutation in, you have to remember, very three specific proteins. It's going to be ankyrin, spectrin, band 3, and 4.2. Okay, so this is very important to remember in the context of hereditary spherocytosis. Okay, so it's an autosomal dominant mutation in ankyrin, spectrin, band 3, and 4.2. And you do something called sorry, yeah. So you do something called osmotic fragility test and flow cytometry with EMA levels. Okay, so what are these? So osmotic fragility basically, uh, let me like orient everything together. So first of all, as you can see here, so the defect here is in ankyrin or spectrin or band 3 or 4.2 or whatever it is, right? So the issue here is the cytoskeletal proteins. So if you don't have proper cytoskeletal proteins, obviously the cells are going to be very fragile. They're not going to have the biconcave shape and everything. So when you put them in water, they're going to break down very easily. When water enters inside, usually they have a protective mechanism that prevents hemolysis. However, in this, there is no protective mechanism because of the absence of normal cytoskeletal proteins. So what happens is if you put them in if you make them undergo osmosis, they're going to be very fragile and they're going to cause lysis of cells. And so these cells are positive for osmotic fragility. Okay, another test you do is called flow cytometry. So you pass the cells, is like flow the cells, and you measure EMA levels. So EMA levels are normally present with normal skeletal proteins. However, in hereditary spherocytosis, EMA levels are going to be low. And this is the main diagnostic test seen here, seen in hereditary spherocytosis. Osmotic fragility is not done so much anymore. It's mainly the flow cytometry that is done. And treatment, obviously, it can be an SAQ question. Treatment, splenectomy. Because the main issue here is the anemia caused by the destruction of these abnormal cells in the spleen. So if you remove the spleen, then you have resolve a resolution of the anemia. But is it going to solve the actual issue? No, because the actual issue is a hereditary issue. It's a autosomal dominant mutation, right? So it's a mutation in the production of cytoskeletal proteins. So that's not going to be solved. However, there is going to be symptomatic relief because of the resolution of anemia. Okay. Very similar. What do you see here? So here you see something called elliptocytes. Okay, so this is similar to spherocytosis, but it's called hereditary elliptocytosis. So in case they bring the picture, you need to mention elliptocytes because these are kind of elliptical, the oval shaped. Okay, the only difference here is the cytoskeletal protein that is involved. However, no need to know too much about it. Just know the name. Yeah. Okay. So can anyone tell me what we're seeing here? So here we're looking at something called helmet cells or schistocytes. Okay, so schistocytes are seen in a very specific kind of anemia called as microangiopathic. What's the word? Microangiopathic hemolytic anemias, right? Microangiopathic hemolytic anemias. And the main two that you need to know is going to be hemolytic uremic syndrome and thrombotic thrombocytopenic purpure. Okay, so now can anyone tell me what causes hemolytic uremic syndrome? So now we're talking about the context. Okay, because remember, for every disease, you need to know all of these things. Okay, so what is the context? What age group do you see hemolytic uremic syndrome in? It is usually seen in children. Okay, and then, uh, what causes it? Usually, it is caused by Shiga toxin, caused by EHEC or enterohemorrhagic E. coli. Okay, what are the signs and symptoms? You can have hematuria, okay, and then hematuria, fever, anemia, thrombocytopenia, okay, and then interpretation of histology. You see schistocytes, which are very specific for these. Diagnostics. Schistocytes are also seen in something else, such as aortic stenosis. Essentially, what these are, basically, when they pass through the spleen or when they pass through anything that causes mechanical stress, they can deform the shape, right? So when they're passing through the spleen in this case, they what is it called? They undergo shear forces. Okay, they get forces on them, or they undergo forces, and this causes changes in the shape of the RBCs. This can also happen in aortic stenosis. It's a less common cause, however, it happens because of the mechanical shear of the stenosis of the aortic valve. So this is something like a fun fact to know. I don't know if it's important for you guys specifically, but for schistocytes, remember this hemolytic anemia, microangiopathic hemolytic anemia. So now the two I mentioned, hemolytic uremic syndrome and TTP. TTP is going to be the absence of one specific protein. Um, can anyone tell me what protein that is? So it is going to be ADAM TS13 protein, okay? So TTP, it's an inherited condition, whereas hemolytic uremic syndrome, it is an acquired condition. It's an infection, basically. So clinical features, you have thrombocytopenia, microangiopathic hemolytic anemia, renal involvement, etc. Okay. However, for TTP, one very, very important distinction between TTP and HUS is going to be the CNS involvement. Okay. So CNS involvement is seen in TTP, but not seen in HUS. To remember the differences between HUS and TTP, sorry, to remember the symptoms of both of these, you can remember the mnemonic FAT right now. Okay. So FAT, fever, anemia, thrombocytopenia, right now. Renal involvement, now, but it's only for TTP. It's neurological symptoms. Okay? Hemolytic uremic syndrome usually affects children. This usually affects the adults. Here you can have diarrhea. There can be other causes, but most commonly it's by sugar toxin by EHEC. And here it's ADAM-TS13. So ADAM-TS13 is a protein that cleaves von Willebrand factor. Okay, so when you can't cleave von Willebrand factor, these von Willebrand factors are huge and they kind of activate on their own. Okay, so this causes thrombocytopenia and thrombosis and the stuff that you see here, basically, hemolytic anemia. Okay, so now, what are we seeing here? This is very classic.
G6PD.
Yep. A G6PD deficiency, in other words. What do you see here? These are bite cells, and these are, what are these? So
Heinz
these are
bodies.
Heinz bodies. Yes, perfect. So these are Heinz bodies, and these are bite cells. Again, you can see here that this is a special stain that's being used. It's called supravital stain, and it checks for small inclusions in the body, or yeah, remnants of DNA or RNA in the body, which is Heinz bodies, and this is bite cells. Okay, so this indicates a G6PD deficiency. So what is the context here? Someone who is mainly asymptomatic, maybe the symptoms are brought on symptoms of anemia, that is, let's say pallor, jaundice, not hepatosplenomegaly, mainly pallor, jaundice, fatigue. And this is brought on by either a recent viral infection, or it could be a medication called dapsone, or it could be consumption of fava beans, right? So signs and symptoms, as I mentioned, interpretation of histology, we mentioned diagnostics, we can measure G6PD levels. So G6PD is glucose 6-phosphate dehydrogenase levels, okay? Treatment is going to be avoiding triggers. So avoiding fava beans or medications that might precipitate this infection. Otherwise, it's a fairly benign condition. Okay, so here, can anyone tell me on this side, what can we see here? This is a difficult image, to be honest. But can anyone tell me the general differential diagnosis you have in mind, basically?
Is this nucleated
Yeah,
RBC?
you can see nucleated RBCs, very good. You can also see polychromasia. So there are different colored RBCs. Okay, here you can see something called, like the RBCs are kind of clumped together, right? So this is called red cell agglutination. Now, can you tell me what disease? Sorry, what disease we're talking about here?
Autoimmune hemolytic anemia.
Perfect. So this is autoimmune hemolytic anemia. So the context, it can be a young woman with a recent viral infection. Now they're presenting with symptoms of anemia. So it can be a fatigue, pallor, jaundice. Again, with hemolytic anemia, always think jaundice, hepatosplenomegaly. Okay, all right. Interpretation of histology, as you correctly mentioned, nucleated RBCs, polychromasia, and then red cell agglutination, etc. Okay, diagnosis, again, diagnosis, very important. What test do we use for diagnosis here? Coombs test, okay? Coombs test is very important for diagnosis. Okay, so they might present with fatigue, pallor, jaundice, recent viral infection. High reticulocyte count is very important because their cells are undergoing hemolysis, right? So to compensate for this, the bone marrow is producing more and more and more cells, which results in abnormal or immature cells being in the blood, such as the nucleated RBCs and the high reticulocytes. Okay, so in cold hemolytic anemia specifically, you can see red cell agglutination and you can see target cells as well. Okay, so you can see some target cells here, and red cell agglutination. So this is more of warm, and this is more of cold. Okay, treatment is to avoid triggers. Um, okay, so the causes, can anyone tell me one co cause for cold autoimmune hemolytic anemia?
Isn't SLE?
Uh, Correct, but for warm hemolytic anemia, okay? So for cold hemolytic anemia, mainly mycoplasma infections and also EBV infections, if I'm not wrong. So this is a quick table that I made from, yeah. So this is a quick table. I took help of ChatGPT as well, but it's a very comprehensive table from the lecture as well. So in warm hemolytic anemia, the main um, antibody that is involved is IgG, whereas for cold, it's IgM. And here, the mechanism is extravascular hemolysis. Okay, so here you see more of like spherocytes and you see more of extravascular hemolysis, so jaundice, hepatosplenomegaly, whereas here it's going to be complement-mediated intravascular hemolysis. Okay, and you see RBC agglutination because the problem is inside the RBC, sorry, inside the vessels. Okay, so this is going to be strongly positive for IgG, and this is strongly positive for complements such as C3. And common causes, as you mentioned, SLE is going to be a common cause for warm hemolytic anemia, whereas for cold hemolytic anemia, it's going to be mycoplasma and EBV. Okay, so here splenomegaly and jaundice, here mostly intravascular symptoms such as dark urine or cyanosis or stuff like that. So intravascular symptoms. Treatment is avoiding triggers and giving immunosuppression because it's an autoimmune disease, so you want to immunosuppress them by giving them steroids. Uh, yeah, so important to know here, extravascular, intravascular. You can remember this by, warm people, they're very extroverted, whereas very cold people, they're introvert. It was a very big generalization, but just for the sake of remembering this. Okay. All right. So now, what do you see here? Okay. So
Fatty
here,
bone marrow?
yeah, fatty bone marrow. Very good. What disease are we talking about here, usually?
Aplastic anemia.
Perfect. So here, as you correctly mentioned, there is increased adipocytes and there is hypocellularity, which means there is not enough cells, essentially. So if they ask you to interpret the image, hypocellular bone marrow and also increased adipocytes. This is seen in aplastic anemia. Now, the context here, it's going to be variable. There are so many things that can cause aplastic anemia. It can be inherited causes. Can you name the most common cause of, not the most common, like one of the most commonly discussed topics in our blog for aplastic anemia? Inherited causes, I mean.
Fanconi anemia?
Fanconi anemia, very good. So it's going to be Fanconi anemia, okay? So those are inherited causes. It could be viral infections, it could be SLE, autoimmune diseases, it could be malignancies. So there are many, many different things that can cause aplastic anemia. So the context may be variable. So the signs and symptoms, again, of anemia, but aplastic anemia means that yeah, it's going to be signs and symptoms of anemia, actually. Okay, yeah. Interpretation of histology, as you mentioned, hypocellular bone marrow, increase adipocytes. Diagnostic anemia, this is done through bone marrow biopsy. Diagnosis depends on the underlying cause, which can be variable. As I said, treatment also depends on the underlying cause. So one common factor that you mentioned, inherited cause, is Fanconi anemia. So for context for this, it's going to be a young patient, usually, because this is an inherited disorder. It's going to have, they're going to have other dysmorphic features, such as thumb and radial deformity. So they might have polydactyly, okay, increased number of fingers, and they might also have radial defects, okay? So radial defects, also short stature, and diagnosis. Can someone tell me what we use to diagnose Fanconi anemia?
It's a chromosomal instability test.
Perfect, very good. So chromosomal instability test. So we test for chromosomal breakage with DEB. I forgot the full form. I don't think it's important, or mitomycin C as well. So chromosomal breakage through mitomycin C and genetic testing for FANC, which is a common mutation. And this is an autosomal recessive mutation which causes impairment of DNA repair. So normally DNA is repaired spontaneously through the repair mechanisms that we have in place. However, if there is a mutation of one of those mechanisms, then that will cause something that causes Fanconi anemia, or impaired DNA repair, I mean, and this causes instability of the DNA. Okay, so here, one thing I wanted to mention was that decrease in all three cell lines. So it's aplastic anemia, and decrease in all three cell lines means that you have symptoms of anemia, thrombocytopenia, and also leukopenia. So anemia, it's going to be fatigue, pallor, that's it, shortness of breath, etc. For thrombocytopenia, maybe increased bleeding, right? So mucocutaneous bleeding, or let's say a petechia or purpura or ecchymosis. Or leukopenia, leukocytes are usually used to fight off infections. So here you can have recurrent infections, recurrent pyogenic infections, or granulomatous infections. Okay, so these are the symptoms whenever you think of all three cell lines decreasing. So pancytopenia, you think about what symptoms each cell line can present with. Okay, so decreased cellularity, increased adipocytes. I think we covered everything. So that is the end of the hematology section. Okay, it took us 1 hour. That's good. Okay, so now we'll move on to oncology. This is also a huge chunk, and it's often like very intimidating. But honestly, it's a lot of memorization. But once you memorize, it's kind of either you know it or you don't. It's kind of yeah, either you know it or you don't. So it's very important to know the translocations, the blast percentage, the factors, etc. So would you guys like to take a small break, or do you guys want to start now? Actually, let's take a 5-minute break, if that's okay, and then we'll start again. Okay, welcome back. Okay, now we'll start with oncology. It's a very favorite topic of mine, and it seems very intimidating. Even when I did it in third year, it was very overwhelming, especially with all the lymphomas, the leukemias. They all seem very similar, but not so similar. So let's go through it together. If you have any questions in between, please let me know. Okay, so let's start off with this. So this is, can anyone tell me if there's anything wrong here? No, correct. So this is a normal lymph node biopsy. Okay, so what are the zones of the lymph node? So this is a normal lymph node. So here, you have a capsule, okay? You have a cortex. What is the main cell in the cortex? That's going to be a B cell, okay? Then you have the paracortex, okay? Beside the cortex, which is going to have T cells. And then you have the medulla, which is going to have some cells called histiocytes, okay? Now, something about these follicles are very specific. Are they primary follicles or secondary follicles? They are uh, secondary follicles with germinal centers. Okay, so because of these germinal centers, they are called secondary follicles. So again, you have the cortex with B cells, paracortex with the T cells, and then you have the medulla with histiocytes. Okay, so now that we know what's normal, okay, the animation didn't work here, however, okay, so here you can see a lot of follicles, right? So this is follicular hyperplasia, and this is sinusoidal hyperplasia. So this happens usually as a reaction to some sort of infection. So this can happen as a result of, some sort of viral infection or bacterial infection, and you can have either hyperplasia of the follicles more commonly, or you can have hyperplasia of the sinusoids or the histiocytes, right? So follicular hyperplasia, you might think, okay, someone with an infection, he came to the hospital and he has a lymph node swelling. How do I know it's just hyperplasia and not cancer or lymphoma, right? So we have to think about three important differences between follicular hyperplasia and a follicular, let's say, lymphoma, right? Follicular lymphoma. So number one here, the architecture of the lymph node is still maintained. They are very, let's say, polite. They're still in follicles. and the cellular architecture is still the same. Okay, so there are no abnormalities, as we'll see later in follicular lymphoma, which is distorted architecture, basically. Then we see the then we see the cells themselves, which will require a bit more closer investigation, but that is also one of the differences. In follicular lymphoma, it's going to be a monoclonal proliferation, whereas for follicular hyperplasia, it's going to be a polyclonal differentiation or polyclonal proliferation. So all the cells are going to be reacting to this infection equally, right? So you're going to have polyclonal cells, normal or retained cellular architecture, and you're going to have tangible macrophages. This is just something that you need to mention. These are three differences between follicular hyperplasia and follicular lymphoma. Okay, sinusoidal hyperplasia, just remember this picture. There's not much to do with this. Now, can someone tell me what you're seeing here? What are these cells?
Lymphocyte?
Lymphocytes. Very good. Are they normal lymphocytes?
I don't think so.
No. Yeah, you're right. So these are atypical lymphocytes, okay? So these are atypical lymphocytes which are usually seen in a very specific infection. Can anyone tell me what it is?
EBV?
EBV, very good. Infectious mononucleosis, which happens in younger population, right? And it can cause cervical lymphadenopathy, often confused with cancer. Also, EBV is also associated with cancer. So this is very important to know and to look out for. So this is atypical lymphocytes seen usually with EBV. So mention causes, as you mentioned correctly, EBV. Less commonly, it can also be caused by CMV, but EBV is the most common cause. So with EBV, let's say, what are the specific acute lab findings? So what tests will you do and what are the acute findings? So the acute findings you will have are IgM, viral capsid antigen, IgG, viral capsid antigen, and what's it called? Anti-early antigen IgG, okay? So these three are very important to know. They can come as SAQ. One thing that if they mention chronic, that's when you mention EBNA. I forgot the full form, but it's EBNA1 IgG. That happens, that shows up after 4 weeks and it remains chronically. Okay, so acute is going to be IgM, VCA, IgG, VCA, and anti-EA IgG. Okay, so this is infectious mononucleosis seen with atypical lymphocytes.
What is the
Oops.
chronic you said?
EBNA. It's mentioned in your slides as well. EBNA1 IgG.
Thank you.
Okay, welcome. So it was supposed to be an animation, but it didn't work. So this is very commonly known as a Reed-Sternberg cell. So what disease do you see this in?
Hodgkin lymphoma.
Perfect. Hodgkin lymphoma. And also another question. What markers are positive in Reed-Sternberg cells? It's going to be CD15 and CD30. Okay? So very, very important to know. Drill this into your head. 15 times the 2 nuclei that you see here is equal to 30. Okay, so CD15, CD30 is common in, is always seen with Reed-Sternberg cells. Okay? So this is classically for Hodgkin lymphoma. So Hodgkin lymphoma, it is a type of lymphoma that happens in different populations. There are different types of Hodgkin lymphoma. It can be classical, non-classical. Classical can be either nodular sclerosis, or it can be mixed cellularity, lymphocyte rich, and lymphocyte depleted. Okay, so nodular sclerosis is the most common type, and it is the only type that happens predominantly in females. The others are more common in males. Lymphoma in general is a bit more common in males than females. Okay, so now for Reed-Sternberg cell, we said that it produces CD15 and CD30. Now, because of these cytokines, these production of cytokines, they cause something called B symptoms. So lymphoma, very common if, so this is a common context with lymphoma, is that if the patient presents with B symptoms. What are B symptoms? Night sweats, fever, loss of appetite, what else? Weight loss. Okay, so these are B symptoms. These are caused in lymphoma because of the production of the cytokines. Okay? Okay, so now that we mentioned the 4 kinds of Hodgkin lymphoma, what is this? So,
Nodular?
yeah, nodular sclerosis. Very good. So as you can see, there are nodules here, And there are also sclerosis. Okay, so remember this picture. It's good for those who have photographic memory. So again, for this, the approach is a bit different because you need to know the population that it affects, the type of cell that is involved, what are the CD markers, what if there is a translocation that is specific to know, and what the prognosis is. Okay, so nodular sclerosis, it happens, as I mentioned, in young females. Okay, it usually is a mediastinal presentation. Okay, mediastinal lymph node. So mediastinal lymph nodes, sometimes they might present asymptomatically. It could be incidental or B symptoms, or it could be shortness of breath, or it could be superior vena cava syndrome, which is an oncological emergency that you guys took, right? Okay. So this is nodular sclerosis. And now what are the type of cells involved? It is negative for B and T cell markers, and it's going to be positive for CD30. Very, very important to know, CD30. So it's a common cancer among females, positive for CD30. No specific translocation that is mentioned, and it's a good prognosis. Okay? Okay, now this is nodular sclerosis. Can anyone tell me what this is?
Mixed
Perfect. So this, you can see there are so many different kinds of cells. There are some cells that are basophilic, some cells are eosinophilic. You can see a Reed-Sternberg cell as well. So this is mixed cellularity. Mixed cellularity happens at an older age, and it is predominantly in males, and it has a strong association with EBV infection. Okay, so CD markers are going to be B cell markers, if I'm not wrong. And the prognosis, it's not as good as nodular sclerosis, but also not as bad. It's a fair prognosis, okay? Okay, so you see Reed-Sternberg cells here. The other two, I haven't brought images for them, the lymphocyte predominant and lymphocyte depleted. However, can you tell me which one has a very bad prognosis, the lymphocyte predominant or depleted? It's going to be the lymphocyte depleted, okay? Because lymphocyte depleted has mostly Reed-Sternberg cells. The normal lymphocytes are not really present. So for these cells, one thing you can remember is Reed-Sternberg cells are an indication of worse prognosis. So in lymphocyte depleted, you see a lot of Reed-Sternberg cells, which means that it has a poor prognosis. A way to remember this is that lymphocyte poor or lymphocyte depleted, as in like poor, so it's a worse prognosis, and a lymphocyte rich or predominant has a better prognosis. Okay, so that covers our Hodgkin lymphomas. Okay, now we will move on to this. What is this? This side here. What can you see?
Isn't this CLL?
Yes. CLL, in other words, SLL as well. So they're used interchangeably, but the main difference is SLL is seen in the lymph nodes and CLL is seen in the blood. Okay, so SLL is called, oh my God, sorry. So SLL or CLL, small lymphocytic leukemia, small lymphocytic lymphoma, or chronic lymphocytic leukemia. Okay, so here, can you tell me if the cells are mature or immature? It's going to be mature, right? Yeah, it's going to be mature cells. Okay, and what are these cells here? It's going to be, I don't know if it's mentioned in the lectures, is it?
Monocytes?
Yeah, but there's a specific name. It's called smudge cells. Okay, it's basically like if you take a cell and like smudge it, basically. Or popcorn, I've heard that as well. So these are smudge cells. I don't know if they're mentioned in the lecture, but it's just good to know for USMLE as well. So these are called smudge cells. They're seen in CLL very distinctly. And so population, it usually covers older adults, although it's small lymphocytic. Remember, it covers older adults and more than 60 years old usually. And the markers that you're going to see are CD5 and CD20. Very, very important to know. One way to remember this is S looks like a 5, right? So CD5, this is almost very specific. You only see it in SLL and one other disease we're going to talk about. Okay, so you see CD5 and CD20. Very important. And B cell markers as well. Okay, because these are mature B lymphocytes. Okay, no translocation. Prognosis is slow growing, and I believe it's a fair prognosis. Okay, so can anyone tell me what this is?
Follicular lymphoma.
Follicular, very good. Yes. So this is follicular lymphoma. So remember when we first talked before about follicular hyperplasia, remember the follicles were very well defined. The architecture was very much maintained. However, here you can barely differentiate between the follicles and the the parafollicular regions. So here this is a lymphoma. Although also if you look at the cells themselves, they're going to be monoclonal. They all look the same. They don't have any difference because this is a proliferation or what do you call it? Like a proliferation of only one kind of cells or B cells. Okay. So population, usually it affects old people, follicular lymphoma. Type of cells, B cells, as I mentioned. CD markers, very important, B cell markers. So what are B cell markers? CD19, CD20, 21, and also specific for this is going to be BCL2 and BCL6. Okay. And also CD10, as I mentioned. Okay, so can you tell me the translocation for follicular lymphoma? Okay, it is going to be 14 and 18. Very, very important to know. Follicular lymphoma, 14 and 18 translocation. Okay. And then, um, so basically what this does is this translocation, it causes an overexpression of BCL2. So what is BCL2? It is an anti-apoptotic gene. So if you have overexpression of something that is anti-apoptotic, cells that are supposed to die or are defective, they are not dying, right? So you have proliferation of these cells. In these case, B cells. Okay, so this is follicular lymphoma. Let's move on. So now we have something. Can anyone tell me what it is?
Mantle.
Mantle cell lymphoma, very good. So this is mantle cell lymphoma. Mantle cell lymphoma usually happens in middle-aged men. So as the name suggests, men, right? Mantle, middle-aged men. Okay, so here, can anyone tell me a very specific translocation for mantle cell lymphoma? It's going to be 11 and 14. Follicular is 14 and 18. Mantle is 11 and 14. Okay? So translocation is going to be 11 and 14. CD markers are going to be, again, CD5, specific here as well. So we mentioned CD5 in SLL and mantle cell lymphoma and one more place. No, actually, these are the only places. So mantle cell lymphoma and SLL. Okay? And what do you call it? Another very important marker is going to be cyclin D1. Okay, so that is mantle cell lymphoma. Then, can anyone tell me what this is? Okay, so this is going to be what do you call it? Diffuse large B-cell lymphoma. So diffuse large B-cell lymphoma, what you need to know about it is that it's diffuse, which means it's very aggressive. It can affect what do you call it? It can spread very fast. And it can happen as a result of a lot of other hematological conditions. Okay, so a lot of other lymphomas um, or like myelodysplastic syndromes, they can ultimately result in B-cell lymphoma. Okay, so what do you call it? The population is that it can affect any age groups, right? Both age groups. And as it's B-cell, you think about B-cell markers. So 19, 20, and also CD45. Okay, no specific translocation here. It can be an end product of a lot of other lymphomas. And prognosis, bad. Bad prognosis. It's an aggressive disease. What do you see here? What is this classic appearance? So this is going to be
Burkitt.
stark sky appearance. Sorry?
Is it Burkitt's lymphoma?
Yeah, perfect. Yeah. So this is Burkitt's lymphoma or starry sky appearance, classically seen in Burkitt's lymphoma. So what is the translocation in Burkitt's? It's going to be 8, 14. Okay, one thing you can remember this by is Burkitt's lymphoma, usually the population is that it happens in children. Okay, so it makes sense that the translocation here is the smallest number, which is 8, 14. Okay, so others are, as we mentioned, 11, 14, 14, 18, but this is 8 and 14, which is the smallest. And this goes to say that, I was going to say that population is going to be young children. It can be endemic or sporadic. Endemic in African regions, it usually has neck mass or neck swelling, very rapidly swelling of the neck. Okay. All right. And these stars are basically their histiocytes among malignant cells. Okay. Type of cell, B cell. And translocation, as we mentioned, prognosis, it's fairly good, I believe. No. Actually, it's very aggressive. Yeah, it's an aggressive lymphoma. Prognosis is not good. Okay. Can anyone tell me what this is? Okay. So this, it's a very difficult histology, actually. Even if I saw this, it's kind of nothing, honestly. But this is acute lymphoblastic lymphoma. Okay. So this is lymphoblastic. So which means immature cells, right? It's not mature cells. The previous one that we took was lymphocytic lymphoma. So those are sites. They are already matured cells, but these are blasts. Okay. So now can anyone tell me since they're blasts, what markers are we looking for? So since they're blasts, we're looking for a very specific marker called TDT. So this can come as an SAQ as well. So we're looking for TDT, and we're looking for what do you call it? Uh, we're looking for CD99. Okay, so lymphoblastic lymphoma, this happens usually in children. Okay, it can be either T cell or B cell. So depending on that, the markers are going to depend on that. So T cell is going to be CD2, CD3. B cell is going to be 1920. Okay, CD markers, you need to remember TDT as well, and CD99. Translocation, it's nothing specific, I believe. Yeah, nothing specific. Prognosis, it's bad prognosis because these are immature cells. These are very aggressive cells. Okay. All right, so these are that was lymphoblastic lymphoma. So I think one of the last ones here. Can anyone tell me what this is? So this is going to be anaplastic large cell lymphoma. Okay, so anaplastic means obviously anaplastic. Whenever you hear the word anaplastic, it indicates that it's a very not matured, not developed. It's a very early cell, and it indicates a very aggressive disease. Okay, so that's the case here as well. The population, it can affect any population. It's very aggressive type of cells. It is a T cell lymphoma. CD markers, CD30, very, very important. CD30 is specific for anaplastic cell lymphoma. And there are no specific translocations. However, the prognosis is very, very bad. It can affect any age group, bad prognosis, CD30. Okay, that's all you need. Okay, lymphoma staging. This is also very, very important. It can come as an MCQ or an SAQ. So stage 1 is one lymph node region involvement, okay? One local lymph node. So if I say para-aortic lymph nodes or cervical lymph nodes or iliac lymph nodes, one region of lymph nodes. 2 is two regions of lymph nodes, so para-aortic and cervical, let's say, but on the same side of the diaphragm, okay? On the same side of the diaphragm. Third, stage 3 is on two sides of the diaphragm. Okay, so it's either cervical and let's say internal iliac lymph nodes, or yeah, so two sides of the diaphragm. Okay, and then stage 4 is if there is any extra lymphatic or extra lymphatic involvement, such as the liver, the spleen, or the bones. Okay, so those are important. Now, I want to ask before we talk about this, let's say a patient comes in and they have B symptoms, they have involvement of the preauricular lymph nodes. What stage of lymphoma is this?
1.
1, very good. So now let's say in addition to this, in addition to these lymph nodes, they also have an involvement of the bone. What lymphoma is this? What stage?
4.
Good. Good, very good. Anytime you hear bone involvement or liver or spleen involvement, you immediately think of stage 4. Okay, so this is one miscellaneous. I just added it for the sake of completion, but it's not that high yield, I would say. Can anyone tell me what this disease is? So this is mycosis fungoides. I hope I'm pronouncing that correctly. It's a malignant T-cell lymphoma. And this usually the main symptom that the patients present with, by the way, the patients are usually 40 to 60 middle-aged patients. And they present with something like skin rash, okay? And yeah, so type of cell, T cells. Markers are not really important. CD4 positive T cells, so CD4. And translocation is not that important. And they can, if the cells get into the bloodstream, they can cause something called Sézary syndrome. Okay, so that is important for mycosis fungoides. That's all you need to know, basically. And you can see something called microabscesses, Portier's microabscesses? Yeah, Portier's microabscesses. Okay, can anyone tell me what they're seeing here? What disease are we thinking?
ALL.
ALL, very, very good. So now we've moved on from the lymph nodes to the bloodstream. Okay, so this is acute lymphoblastic leukemia or ALL. So ALL happens mostly in children, so that's the population. In fact, it is the most common cancer of childhood. Okay, and lymphoblastic leukemia, which means that it is immature cells, immature lymphocytes, right? So symptoms they may present with can be constitutional symptoms and reduced cell lines. So 3 cell lines are reduced, or it can cause pancytopenia, right? Because these are the bone marrow is producing so many of these lymphoblasts that the normal cell lines are suppressed. So again, 3 cell lines are reduced, so that means symptoms of anemia, symptoms of thrombocytopenia, symptoms of leukopenia. Okay, now blast percentage for any acute leukemia. What is the blast percentage going to be more than? It's going to be more than 20%, okay, for acute leukemias. Okay, so what are the causes of ALL? The causes of ALL are going to be previous radiation exposure. Most commonly, it's going to be idiopathic, or if there's family history of ALL, or if, let's say, some infections. Okay, so interpretation of image, if they say, so you'll say there are lymphoblasts. I've seen this in a previous SAQ. So you'll say that there are lymphoblasts with increased NC ratio. What is NC ratio? It's going to be nucleus to cytoplasm ratio. Okay, so high nucleus, as you can see, most of the cells are covered by the nucleus, and a low cytoplasm or scant cytoplasm, and it's deeply basophilic. Blue for basophilic, right? So a high NC ratio, lymphoblasts, scant cytoplasm, basophilia. A basophilic cytoplasm, not basophilia as in like there are basophils, okay? Okay, so I'm focusing more on ALL because it was one of the PBL cases, I believe, and it was very important. So you treat them with chemotherapy. Early induction of chemotherapy is very important. There are 3 stages. You have induction, consolidation, and maintenance of chemotherapy. If there are kind of involvement of any chromosomal, any specific, let's say Philadelphia chromosome involvement, then you can also do targeted chemotherapy. And very, very important for ALL, it happens in children, and there might be involvement of the CNS, which rapidly degrades the prognosis of ALL. Okay, so you need to keep in mind the CNS symptoms. So you need to do frequent screenings of the patient, do prophylaxis for CNS. You can give them intrathecal chemotherapy, which is inside the spinal cord, and yeah. That's mainly it for ALL. Is there anything else I have? Yes, the prognostic factors. So there are favorable prognostic factors and unfavorable. Now, for the past batches, I believe it was not that mentioned, the prognostic factors were not that asked about, but in the transcriptions, they mentioned how it is kind of important to know. But it's very simple, basically. If CNS is negative, favorable prognosis. Very simple. Okay? If B cell, which is more common with these lymphomas, leukemias, then it's favorable. T cell, always, it's a bit more complicated. So always think B cell. favorable prognosis. Then hyperdiploidy, you can think of it as kind of like the more the merrier, you know? So the more diploidy or the more chromosomes, basically, a favorable prognosis. And if there is rapid early response, obviously makes sense, or minimal residual disease is very less. So after you induce chemotherapy, you give the first cycle of treatment. If the minimal residual disease that is left is very less, then it's going to be a favorable prognosis. Everything else is going to be unfavorable prognosis. Okay, so that's it for ALL. Hopefully, if there is an SAQ, remember that it happens in children. Most common cancer, symptoms of pancytopenia. Risk factors can be radiation exposure, it could be idiopathic as well. And then interpretation of image, I told you, start chemotherapy as soon as possible, and you also give them CNS prophylaxis because it is very, very important, and there can be CNS involvement, which rapidly degrades the prognosis of the patient, if not caught earlier. Okay, what are we seeing here? Okay, this is going to be myeloblasts with our rods, right? So myeloblasts mean it is of myeloid lymph lineage, and these are our rods. Okay, so this is acute myeloid leukemia. Again, blast percentage more than 20%. That's why it's acute myeloid leukemia. Okay, so for acute myeloid leukemia, you need to know that it happens in adults. It can result as a result from myelodysplastic syndrome, so that's one of the risk factors. Again, symptoms are going to be symptoms of all three cell lines being reduced: anemia, thrombocytopenia, leukopenia. Okay, there are certain translocations that have favorable, unfavorable prognosis. The one that I like to remember the most is 1517. It's a favorable prognosis. 57, or the stuff that's ending with 57, has an unfavorable prognosis. Okay, now speaking of 1517, what does this indicate? So this is acute promyelocytic leukemia. Okay, so acute promyelocytic leukemia happens as a result of 1517 translocation, as I mentioned, and it's something called PML and RARA, or RARA mutation. So this is retinoic acid receptor mutation, which causes arresting of these promyelocytes. So it doesn't help, or it doesn't let these promyelocytes mature. Okay, so this is a subset of acute myeloid leukemia called acute promyelocytic leukemia, which is a specific type, M3 subtype. No need to know, but yeah, M3 subtype. And you can see a bunch of our rods. So if you see a bunch of our rods in cells, that is called acute promyelocytic leukemia. Very, very important to know, and this can come in the SAQ as well, is that the translocation is very important, 1517 PML RARA. And how do you treat this? You give all-trans retinoic acid. Very, very important. As soon as possible, you give all-trans retinoic acid. To prevent what? To prevent DIC. All-trans retinoic acid, you give them because the retinoic acid receptor is not working. It's not helping with the maturation of promyelocytes. So if you give them the retinoic acid receptor, it's going to help with the maturation of the lymphocytes. The promyelocytes. Okay, so you give them all-trans retinoic acid immediately, monitor for DIC, very important, which is an oncological emergency that can happen here. Okay, all right. Okay, now this one, it was one of the morphological objectives, but I don't know if it's mentioned in the slides. I couldn't find it. Maybe it was somewhere I didn't look. Can anyone tell me what this is? So this is a ringed sideroblast. Okay, so this is a ringed sideroblast. And can anyone tell me what these blue dots are? So these blue dots are called are iron, basically iron deposition, and this is a part of myelodysplastic syndrome. So you see very specifically ringed iron sideroblasts, and you can also see pseudo Helget something anomaly as well, but those are not part of your morphological objectives. So myelodysplastic syndrome, it's a clonal stem cell disorder, and it has a risk of progression to AML, hence why I'm mentioning this. There's a fairly high risk of progression to AML of myelodysplastic syndrome, and that's why it's important. Okay, So these are straight from the slides. So blast 20, more than 20%, remember, acute leukemia. This is just for a reminder, basically. Our rods, myeloid blasts. Start all-trans retinoic acid receptor immediately if you suspect APML. Yeah, okay. As we mentioned, for prognosis, minimal residual disease is very, very important. For these, I guess you can memorize them. I've never seen them being asked before, to be honest, but hyperdiploidy is a good prognosis for ALL, and FLT3 is an adverse prognosis for ALL. Okay, CNS prophylaxis, as I mentioned, very essential. MDS, it's a clonal dysplasia, cause cytopenias, and risk of AML. All there is to know. Okay, and these things you can read, honestly. But these things are more important for MCQ, not for SAQ and OSPE. Okay, so quick comparison between AML and APL and MDS. Okay, so ALL happens mostly in children. AML is more in adults. APL is also in adults. MDS is in the elderly mostly. Okay, so ALL, remember lymphoblasts. Remember that good prognosis, initiate chemo properly, do proper CNS prophylaxis, and you're good. Okay, AML happens in adults, myeloblasts with our rods. It's again acute, so more than 20% blasts, and you can you have some treatment called 7+3, cytarabine, and all of that, but you don't need to know all that. Okay, APL. APL is going to be all-trans retinoic acid and anthracyclines, the treatment. Like sometimes arsenic as well on all of this, but more important to remember is the all-trans retinoic acid. It's an acute emergency, okay? So this is one of the oncological emergencies because it can cause DIC. Then you have myelodysplastic syndrome. It has a risk of AML, and that's all there is to it, honestly. Okay. All right. So here, can anyone tell me what we're seeing here?
CML.
CML, very good. So this is part of the lecture called myeloproliferative neoplasms. And here we talk about four main disorders, as you mentioned correctly, CML. We also talk about polycythemia vera, essential thrombocythemia, and myelofibrosis. Now, I have not gotten all the pictures here because I don't, it's going to take a long time, and I believe other PAL sessions are going to cover it. However, this is CML, this is very important to know. And what is the very specific translocation in CML? So it's going to be 922. Okay, so 922, also known as Philadelphia chromosome. Okay, so this can also come as an SAQ, so it's very important to know. Yeah. So first of all, there are when you suspect someone with CML and you see this peripheral blood smear, you can order two you order bone marrow biopsy, right? And you also order two specific tests. So you order cytogenetic testing and you order molecular testing. So if they say what further investigation to do, bone marrow biopsy with cytogenetic testing and molecular testing. Okay? Now, the age of presentation is usually 50 to 60 years. And speaking of the cytogenetic and molecular testing, in the cytogenetic test, you see the Philadelphia chromosome. So you see the genetics of the cytology, basically. In the molecular testing, you see the BCR-ABL gene fusion. Okay, this BCR-ABL gene fusion will cause increase in one enzyme. Can anyone tell me what that enzyme is? It's going to be tyrosine kinase. Okay, so that makes sense when we talk about the treatment later. Okay, so what are the symptoms that the patient presents with? Population, we said 50 to 60 years, old people basically. Type of cell, it's a myeloid cell. And patients present with pallor, they may present with splenomegaly, even gout or hyperuricemia symptoms. And in the peripheral blood smear, you see something called immature neutrophils or immature neutrophilia. Okay, so first, the step to diagnosis is first you do CBC, then you do peripheral blood smear as we see here, then you do bone marrow biopsy with cytogenetic and molecular testing. Molecular testing, if they ask what technique, it's FISH technique, basically. And these are diagnostic tests, basically. Now, someone might ask, or they might ask in the exam, basically, what is the difference between this and a leukemoid reaction? So leukemoid reaction is seen with basically a reaction to infections, let's say, or like a hyperreaction to infections where the WBCs reach as high as more than 50,000. Okay, so some people might say, okay, but since the WBC is so high, oh, sorry. Since the WBC is so high, it might be because of leukemia, right? That's why it is. But that is actually not the case. And how to differentiate it? You can use alkaline phosphatase. So alkaline phosphatase is decreased in CML because it is something that is seen with mature neutrophils. However, the neutrophils here are not mature, but it is increased in alkaline phosphatase. Okay, so what? Sorry, it's increased in leukemoid reaction. Yeah. So in CML, alkaline phosphatase is decreased, whereas in leukemoid reaction, it's increased. Leukemoid reaction is more than 50,000 WBC, and you don't see immature neutrophils, I believe. Okay. Now, what are the three phases of CML? You have chronic phase, accelerated phase, and blast phase. So chronic phase is when the blast percentage is less than 10%, blast is 10 to 19, accelerated is 10 to 19, and blast is more than 20. When it becomes more than 20, what does it become? We mentioned this before. It becomes acute leukemia. Okay, so this can either be acute lymphoid leukemia or acute myeloid leukemia. Now, because of this Philadelphia chromosome mutation and because of this tyrosine kinase activity, which is increased, what is the treatment that we use? It's going to be tyrosine kinase inhibitors. Okay, so we use imatinib or nilotinib specifically, dasatinib. Those are tyrosine kinase inhibitors in case they ask you to write it in the SAQ. Okay, so when we treat the patient with chronic myeloid leukemia, what are the steps of remission that we're looking for? So we're looking for a hematologic remission. So first, the WBC count normalizes. Secondly, we're looking for cytologic remission. So cytogenetic mutation, which is when the the Philadelphia chromosome normalizes. And we're also looking for molecular remission. So molecular remission is when the BCR-ABL fusion gene neutralizes. So these are the stages of remission of the disease. And this is how you can check for prognosis or the progression or if the treatment is working. Okay, so CML could be a potential SAQ question. So you need to remember it's a myeloproliferative neoplasm. Cytogenetic testing will show Philadelphia chromosome. Molecular testing is going to show BCR-ABL fusion gene. You're going to see this with FISH testing most of the time. Differentiate with leukemoid. Know that it has three phases: chronic, accelerated, and blast. Treatment is with TKIs. It happens in patients who are 50 to 60 years old, has fatigue, pallor, splenomegaly, can have gout or hyperuricemia, and remission can be hematologic remission, cytogenetic, and molecular remission. Okay, these are very important points to know about CML. Okay, so here, if they provide you with the cytogenetic testing, you can see that the chromosomes here and here are translocated. It's not really that obvious, obviously, but these are the translocations that are seen in CML. So what do you see here?
Fibrosis, the marrow.
Yes, perfect. So this is myelofibrosis. You can see classic teardrop cells here. And this is a reticulin stain, and you can see increased reticulin fibers. So this is seen with myelofibrosis. Okay, now, oh, this didn't work, the animation. Okay, no problem. So multiple myeloma, it's a clonal proliferation disorder of plasma cells, right? So what are these things that we see here? This is also a potential SAQ question. I believe we got it in our batch, if I'm not wrong. And so it's very important to know this as well. So what are you seeing here? So these are aggregations, very good. Specifically known as Rulex formation or Rulex formation, basically. So these are Rulex formations seen with multiple myeloma. What are these lesions? These are osteolytic bone lesions, okay? So osteolytic bone lesions. And this is the plasma cells as we're visualizing it here. So multiple myeloma, clonal proliferation disease of plasma cells specifically. And even more specific than that is the IgG. So IgG is more common than IgM in multiple myeloma. And one of the ways to diagnose multiple myeloma is through protein electrophoresis. So you will see, I don't know if I have a picture. Yeah. So this is something that I took from one of your files that you guys made. Mashallah, it was a very good file. So I just thought to, put on a screenshot here. So this is protein electrophoresis. And in normal patients, this spike is not seen. This is called an M protein or M spike protein. Okay. And this is because of this, it's the diagnostic test for multiple myeloma. Okay, so diagnostic criteria, you have three criteria: M protein, more than 10% plasma cells, and also at least one of the four symptoms. So what are the four symptoms in multiple myeloma? The mnemonic is CRAB. So you have hypercalcemia, renal involvement, anemia, and osteolytic bone lesions. Okay. So yeah, that's basically it. So osteolytic bone lesions, they may present with pathological fractures, most commonly bone pain, anemia, fatigue, pallor, jaundice, renal involvement, so renal failure, symptoms of that, and symptoms of hypercalcemia. Okay. Now, so plasma cells, another way to that they can ask is Brown staining will show CD138 activity. So CD138 activity is seen with immunohistochemistry, and it's a surface like a surface marker of plasma cells. So it makes sense if there is a proliferation of plasma cells, you'll have increase in the production of these CD138. Another thing to know is that there are very specific prognostic markers, and I remember them asking this about this specific prognostic markers called beta-2 microglobulin. So beta-2 microglobulin is very, very specific for the prognosis of multiple myeloma. Okay, very important to remember this. If it is less than 3.5, then that is a good prognosis or good prognostic marker. If it's more than 5.5, then it's a bad prognostic marker. Again, the name is beta-2 microglobulin. Okay, you can also have high ESR. These are non-specific things, but more specific is beta-2 microglobulin. Okay, it usually happens in old age. It usually happens in old age, and it's yeah, that's basically it. So again, to recapitulate everything, because I kind of scattered your minds probably. So multiple myeloma, clonal proliferation of plasma cells, most commonly IgG. You see M spike protein on protein electrophoresis. Okay. And then usually it is IgG, as I mentioned, and you also see CD138. The symptoms are CRAB or hypercalcemia, renal involvement, anemia, and osteolytic bone lesions. Okay, usually affects older people, 65 to 70 years of age, and prognosis can be measured with beta-2 microglobulin. If it's less than 3.5, it's a good prognosis. More than 5.5, it's a bad prognosis. Okay, so I hope if an SAQ comes, inshallah, it'll be easy. So this is something that I think that you can go on in your own time. I'm not going to mention. Remember, polycythemia is a JAK2 mutation. The rest we already discussed, but I just put it here in case you want to go through the slides and want a quick reminder. Okay, now can you tell me about this? What do you see here? It's kind of hard to figure out. It's not that specific. So here you can see polychromasia, and you can see reduced cells. It's not really kind of seen with this, but you'll have pancytopenia and polychromasia, and this is seen with paroxysmal nocturnal hemoglobinuria. So the triad for paroxysmal nocturnal hemoglobinuria, and why I'm mentioning is it could be an SAQ question, and it's basically a hemolytic anemia, could be bone marrow failure, hence the pancytopenia, and also venous thrombosis. Okay. So what happens here is you have nocturnal hemoglobinuria that is paroxysmal, as the name suggests. Okay, paroxysmal means that it comes and goes. Nocturnal at night, hemoglobinuria, blood in urine. It happens because of an inherited condition which causes a mutation in PIG-A or it's like a GPI anchor. Basically, it's a cell anchor, and this causes absence in CD55 and 59. Very important to know, CD55, 59, and this is seen in PNH, and they cause the symptoms, the triad that I mentioned, and yeah, these are the peripheral blood smear findings. That's basically all you need to know. Remember the pathophysiology very well. I brought this because sometimes it comes in SAQ. Okay, Now we're reaching towards the end. I know it's not oncology, but I mentioned this just miscellaneous topics basically. So there are there are some disorders which are called which are called platelet function disorders, and they can also come as SAQs. So platelet function disorders basically they increase the bleeding time. However, they do not change the PT and the APTT. One second. So Um, so they mentioned, so they cause problems in platelet function. So what are the two main diseases? We have Bernard-Soulier syndrome, which is a deficiency in GP1B. And we also have a problem in GP23A, which is in Glanzmann thrombasthenia. This causes platelet adhesion, okay? Platelet adhesion, and this causes problems in platelet aggregation with other platelets, okay? Okay, so Bernard-Soulier adhesion with the von Willebrand factor is impaired. And then Glanzmann thrombasthenia, you have problems in platelet aggregation with fibrinogen and with other platelets. Okay, so these are platelet function disorder. I brought this because of this diagram, basically. So this is called a platelet aggregation study. Okay, so platelet aggregation study, they use different kind of aggregates, so ADP, adrenaline, collagen, ristocetin, and they see whether or not the patient's blood aggregates. Okay, so a normal blood would aggregate. Okay, the optical density decreases. So the light does not pass through it, basically, because the blood cell is aggregating. Okay, so this is a normal blood cell. However, in Glanzmann thrombasthenia, which is a deficiency in platelet aggregation, you do not see platelet aggregation. I hope that makes sense. So if this diagram counts, this is a platelet aggregation study. You use different kind of aggregates, see whether the platelets aggregate, and what do you call it? You look at the optical density. I don't think it's very important to know, but basically optical density is how much of light can pass through. So if something is aggregating, it's deficient, it's not letting the light pass through, which is the case in normal patients. However, if the platelet is not aggregating, then it will let the light pass through and the optical density will remain high. So that's it for Glanzmann thrombasthenia. For Bernard-Soulier syndrome in histology, you will see giant platelets. However, I did not bring it, and I don't think it's one of the morphological objectives. However, just know if it comes, giant platelets, basically. Okay, now this one, you can see hemorrhagosis, right? And what disease am I most likely talking about here? It's going to be hemophilia. Okay, so here you see internal bleeding. Now, I want to talk a bit about the coagulation studies that we do for patients with bleeding disorders. So we do a bleeding time, we do PFA, we do APTT, and we do PT, right? And platelet aggregation study in specific cases only. So bleeding time is increased in either platelet, if it's like decreased number of platelets or decreased function of platelets, that will increase the bleeding time. APTT is going to be increased in patients who have intrinsic coagulation factor deficiency. PT, sorry, not PTT. PT is for extrinsic coagulation factor deficiency. Okay, so that's how we can figure out. If there's a special case where you have APTT or intrinsic factor deficiency plus bleeding time, that's going to be a very, very specific case, which is known as von Willebrand factor deficiency. Okay, because von Willebrand factor deficiency is used here in platelet adhesion, and it's also used as a carrier of factor 8, which is an intrinsic coagulation factor. So if you see a deficiency in either the if you see an increased bleeding time plus an APTT, which is a unique combination, always think of von Willebrand factor deficiency. What is the treatment of von Willebrand factor deficiency? It's going to be desmopressin. Okay, or DDAVP, something. D-arginine, D something, vasopressin. Okay, all right. So those are some of the things that I wanted to mention that might come with images in OSPE and also in SAQ. So hemarthrosis, I'm thinking mainly of hemophilia. Most common hemophilia is hemophilia A, which is an absence of factor 8. It can also be hemophilia B, which is factor 9. And hemophilia A and B, they are X-linked recessive diseases, which means that they are most commonly seen in males. Okay, so family history is very important. CBC, coagulation profile is very important as well. And the most common presentation is bleeding in joints or hemarthrosis. Okay, so now can anyone tell me what this sign is?
livido reticularis.
Perfect. Yes. So this is livedo reticularis, and you can see some signs of thrombosis here as well. So livedo reticularis is a very, very specific finding seen in the context of hematology in antiphospholipid syndrome. Okay. So in antiphospholipid syndrome, remember, you'll see repeated first trimester abortions. Again, it's an autoimmune disease. You'll see repeated first trimester abortions. You'll see livedo reticularis. You can see thromboembolism or arteriovenous thromboembolism. And the antibodies you will look for are antiphospholipid antibodies, which can be lupus anticoagulant, or it can be anticardiolipin antibodies, or even sometimes SLE antibodies are positive. Okay. So again, this can come as SAQ as well. So repeated first trimester abortions. Antiphospholipid antibodies are lupus anticoagulant or anticardiolipin antibodies. And you can see these symptoms. Now, for antiphospholipid antibodies, you need to know the targets of the antibodies as well. I don't remember the targets specifically, but the targets are very important, like what these antibodies target specifically. Please go back to your lecture and check. And the treatment is going to be warfarin. Okay? All right. So I believe, yeah. Oh, okay. It's here actually. Yeah, so this is from your transcription. I thought it was very important because it was mentioned as an SAQ. So the minute you see first trimester abortion, think about antiphospholipid syndrome. And yes, these are important. So the targets of these anticardiolipin or anti-lupus anticoagulant antibodies are protein C, annexin 5, and beta-2 glycoprotein 1. Remember these three names, okay? Protein C, annexin 5, beta-2 glycoprotein 1. Okay? So I think, yeah, that was the end of Heme Onc. I just have a bit of microbiology, not that much. Okay, let's get started. So what are we seeing here? What disease are we talking about here?
The P vivax.
Could be VVAX, but in general, we're talking about malaria, right? So, malaria, it's a transmitted condition caused by female Anopheles mosquito, and the diagnosis of malaria is done through smears and through antigen testing. So, smears can be thick or thin smears. How do we differentiate between thick and thin, which can be an OSPE objective, is the thin smears is where the RBCs are intact. So here you can see RBCs which are intact. However, here you cannot see RBCs, you just see random dots, right? So these are thick smears and these are thin smears, okay? Now here in the thin smear, you see a classic headphone appearance. These are seen classically with Plasmodium falciparum. Okay, Plasmodium falciparum is the most dangerous type of malaria. It causes something called black water fever. It can cause black water fever, cerebral involvement, and it causes malignant tertian fever. So every 3 days, malignant tertian fever. Okay, this is it in the thick blood smear where all of the blood cells are gone. And you can see a classic, again, like a headphone appearance or a ring appearance. This is a gametocyte. Again, these are trophozoites and these are gametocytes. Okay, so yeah, that's it for the morphological objectives. But remember, you know, the life cycle, not in that much detail, but remember what happens, the transmission and what kind of people are at high risk, how to prevent, how to detect places which are high malaria and how to, you know, put anti-mosquito repellents, remove pots of still water, etc., or from your microbiology lecture. So again, these are gametocytes. So this is Plasmodium vivax or vivax, okay? So one thing about Plasmodium vivax is the presence of hypnozoites, right? So hypnozoites can maintain or they can stay dormant in the liver, and they require a very specific medication called primaquine to get rid of these hypnozoites. Okay, and this is Plasmodium ovale, and this is Plasmodium malaria. So Plasmodium ovale and vivax, they also cause tertian, sorry. So every 3 days. Plasmodium malaria, it causes quartan fever. Sorry. Um, quartan fever, so every 4 days. So that's something that's important to know. This next one is Plasmodium knowlesi. I don't know if you guys talked about this, but this is a more recent advancement. Basically, it's a specific. It just sometimes comes in the OSPE. You just remember the picture and you write the name, basically. So this is Plasmodium knowlesi. So things to remember about malaria. Remember, Plasmodium falciparum is the most dangerous. It has classic banana-shaped gametocyte and a headphone or a ring-shaped appearance of the trophozoites. Okay, that's it for microbiology. And I believe that's it for my lecture. Thank you so much for joining, and thank you so much for your time. All the best with your exam. I know it's very like a very rushed block. I hope that my lecture could help a bit, even if it did, even if a little bit. Please scan the QR code. Let me know if there's anything I can improve in my lectures. If you have any questions at this point or after the lecture, please feel free to contact me. And yeah, just know for every disease, as I mentioned at the beginning, know the context, know the causes, the symptoms, know how to differentiate between two common diseases, like the leukemias, the lymphomas. They can get a bit confusing. Know the markers. They're like for sure, like sure marks. So know the markers, know everything that is kind of, let's say, frequently asked. So the markers, the CD markers, the types of cells, the characteristic OSPE image. Try to go through this PPT as many times as possible and just flip through the images and try to have like an instinctual diagnosis, okay? So that in OSPE you save a lot of time and you get very familiarized with the images because it's mostly the similar type of images. That's it. Thank you so much for joining. And yeah, all the best. All
Thank
the
you so
best.
much. We appreciate it.
Thank you so much.